everyone, I'm Mrs. Schockel, and today I'm going to show you how to do a basic infant newborn assessment on my 4-month-old son, Joey. Before we get started, I just kind of want to make some points. It's always best to do the assessment in a place where the child is most comfortable, whether that be in parents' arms, in the crib, however they choose. He probably would be most comfortable in my husband's arms, but since he's videoing, I'm going to use his changing mat as an example, so just bear with us. Hopefully he cooperates. You'll notice when kids are sicker, more lethargic, it's kind of easier to do an assessment because they're tired and they don't fight as much. But he's like a healthy infant, so he might fight me a little bit, might get fussy, but I'll kind of show you some tactics on how to distract them. So before we go into the newborn assessment, I'm going to show you how to just take simple vital signs on a 4-month-old. You need to remember that in pediatrics, your assessments are always going to vary. You're not going to perform an assessment on a 4-month-old the same way you would on a 4-year-old or a 14-year-old. If you go into a 3-year-old's room and say, I'm going to palpate your abdomen, or I'm going to take your vitals, they might get nervous or scared because they think you're going to take something from them. Whereas a 14-year-old, if you go in and say, okay, I'm going to press on your belly, they're going to look at you like you're crazy and talking to them like a child. So it's really important to kind of tailor your assessment to the age range of the patient who you're performing it on. And I know Mrs. Huber does a wonderful job in class kind of talking to you about the different developmental stages. So before we begin, I'm just going to show you how to get vitals on him. All right, Bubba. So I'm going to give you your bin to keep you calm and happy. You always want to perform the vitals in your assessment least invasive to most invasive, because if you're going to start with invasiveness, the patient's going to get upset, might start crying, and then it's going to be impossible to do the rest of your assessment. So I'm always going to just take 20 seconds and just look them over head to toe. How does their color look? How is their effect? Are they alert? Are they with it? Are they lethargic? What's their overall general appearance? And then in Joey's case, I'm going to start by looking at his respirations and checking a pulse. So he's a baby, so he is a belly breather. So I can watch his belly for respirations versus his chest. Now, if he was a 4-year-old and he was abdominally breathing, diaphragmatic breathing, that would be a cardinal sign of respiratory distress. So it's definitely important to know the differences in age groups. Then also, since he's under the age of 2, I'm going to check a brachial pulse. Once they're 2 or over 2, it's okay to check a radial pulse. So here we go. I know you're so confused. So I'm going to go into the inner side of his bicep. And while I'm checking his pulse for 30 seconds, I'm also going to then move into his respirations. You can see this is minimally invasive, so it's not really bothering him, and I'm able to get a good assessment without him fussing or crying. Now, if you were to notice that the pulse was abnormal or the respirations were irregular, you would go for a full minute on your assessment. So for blood pressure on a child this age, the best spot is either the calf or that bicep. So you just take the blood pressure cuff, wrap it around, and you would plug it into your monitor. A little trick I always tell my students for this is kids hate their blood pressure being taken. So kind of prepare them. So, you're just going to give your arm or your leg a little hug. Another tip I use is I'll put the cuff on and then I'll kind of do something else for a minute or so, because then they forget about it being taken. And then the next minute I would go and I would actually take the blood pressure. A big thing with kids is you never want to promise that something's not going to hurt. If you say, I promise this isn't going to hurt, and then it hurts them, you completely lose their trust. So it's really important to be honest with them and to describe what it's going to feel like so that they don't think you're lying to them or trying to hurt them. Even though it might not hurt to you as an adult, the pressure of that cuff might really hurt a little kid. So you just need to be honest and kind of transparent. So here's where I would take a blood pressure cuff. Also, the bicep is an okay spot. For children, especially under the age of 1, it is acceptable to take a rectal temperature. I'm going to spare my son in his privacy for this, but you would always make sure you dip it in lubricant, and then you're going to insert it maybe an inch into the rectum. You would not take a rectal temperature if they have signs of rectal bleeding or if they're immunocompromised. In that case, you could either take an axillary temperature, so you would put it right under their arm, And the temperatures always need to be skin to skin, never on top of clothing. You could also take an oral temperature. Side note, red temperatures always mean rectal, so you're not going to want to use the same temperature you use to take a rectal temp as you would oral. Always just get a new fresh temperature probe. And then, hi. So those are your basic set of vitals. We talked about pulse, respirations, blood pressure, and temperature. Then also you would take a pulse ox, which I obviously don't have here, but the machines at the hospital, you just plug it into a finger or a toe, a sticker or the probe, and you give it about 10, 15 seconds to calibrate, and it'll give you their pulse ox. We obviously want 95 to 100% is normal in healthy children. Kids under the age of 3, we always want to take an occipital frontal lobe circumference, or an OFC. And this is going to tell us how their head's growing, if they're at risk for hydrocephalus, microcephaly, things like that. You always want to go around the largest circumference part of their head. You want to make sure the tape is not interrupted by anything. I'm going to pull this a little bit. I don't want to give you a paper cut. Hi. Thank you. Perfect. And then you get your value. You put it on to me. All right. Another thing for infants, typically under the age of 1, are reflexes. Now, my son has kind of grown out of some of his reflexes. As early as 2 months, kids can grow out of them. He kind of lost his startle or his Mara reflex, but whenever my husband and I would go to lay him down in the crib, you would notice he would kind of sprawl his arms out. That's his reflex because he thinks he's falling. He lost that about 2 months, but Babinski, I think he still has. So what you're going to do is you're going to go from the heel to the big toe, and you're going to see how his toes kind of flare out. Let's do that one more time. There you go. Perfect. He also is probably going to have his palmar grasp still. So if I put my finger in his hand, he's going to grasp onto it. Good. Let's see if you have your rooting. Rooting is when you rub on the child's cheek. They should turn to the object, but he's obviously more entertained by the phone. So, and then if I were to put my finger in his mouth, he would suck on it. Okay. So now we're going to continue with our head to toe assessment. I always like to start with the head and kind of literally move my way down the body. That way I don't miss anything. So he is 4 months. He has lost his posterior fontanelle. It is closed, but his anterior is still open. That one doesn't close for 12 to 18 months. So I kind of just act like I'm petting them, essentially, rubbing their head and feeling for it. And you're going to feel it's going to be a nice little divot right at the top of their head. Okay. Now, if that was super sunken, that would be an indication of dehydration. If it was bulging, we would be concerned with hydrocephalus. It is normal for kids when they cry, their fontanelle might bulge, but it's important that it goes back to normal before or when they're done crying. If it stays bulging, that could be a concern for hydrocephalus, cerebral swelling, things like that. I'm going to look at his eyes. I have my pen light here. I'm going to assess for equality. And make sure they briskly react. Level of consciousness. So how am I going to assess if he's alert and oriented times 3? If he knows where he is, who his parents are, his date of birth. He's 4 months old. He clearly doesn't know that. So you kind of need to get creative. This is how I go back to saying your assessment's going to change based off of the age of the patient. So I'm going to check. Does he cry when I change his diaper? Or is he laying limp? That would be abnormal. Is he looking at me? Is he interacting with me? Is he alert? Is he following me with his eyes? Those are all ways you can assess the level of consciousness in a newborn or infant who are not going to be able to tell you yes or no questions. I'm also going to start looking at his face. So does he have any discharge from his eyes? Are his nasal passages open? His lips are nice and pink. They're moist, so I know he's well hydrated. His ears are at level with his eyes. Downward set ears could be a sign of Down syndrome. So you would just be kind of concerned for that if you notice disproportionate facial features. And just kind of feel his lymph nodes. Feels equal, soft. Good job. Look at your... Oh, thank you. You're such a good sport. So I can tell his mucous membranes are super moist. That's a really good way to tell hydration in an infant or newborn. And dehydration in this age is pretty common because new moms might not know if they're feeding appropriately or if their breast milk supply is sufficient. So a lot of times kids will present to the ED with concerns of dehydration. So that's really important to check the fontanelles and their mucous membranes to make sure they're adequately hydrated. Another huge part of hydration status is wet diapers. Are they not making any wet diapers? That would be a sign of dehydration. So then I'm going to kind of move down into the chest region. I'm looking to make sure his chest rise is equal, it's adequate, and also that his belly doesn't look distended before I touch. Remember, you're always going to look before you touch. Take my stethoscope. Okay. And sometimes you might want to let that patient play with this first, feel it, see if they want to do it to you, just to kind of calm their nerves. I'm going to listen to all 4 lobes, and then I'm also going to listen to cardiac sounds while I'm at this spot. Right upper, right lower, and then left upper, left lower. Good job. Now I'm listening to the heart, checking an apical pulse. Good, I hear a normal lub-dub, no murmur, no gallop, no concern for cardiac dysfunction. Since I had the stethoscope on him, I'm going to move right down to the belly and listen for bowel sounds. And he just ate, so they are there. Now, bowel sounds can either be hyperactive or hypoactive or absent. In order for bowel sounds to be absent, you need to listen for a full 5 minutes. Absent bowel sounds is pretty rare, so if you go 10-15 seconds and you don't hear bowel sounds, listen longer or maybe change the stethoscope. I'm also going to palpate on his abdomen, make sure it's soft, non-tender, no masses. Wonderful. Okay, and I'm going to look at your extremities. Now, if they have any IVs placed in their extremities, you want to check the IV site for any redness, swelling, make sure it's not leaking, making sure that it's dry and intact. We already checked your pulse, but I'm going to check your cap refill. So I'm just going to kind of take the nail bed and press down. Wonderful. It's less than 3 seconds. And you're warm and well perfused, which is great. Okay. Let's move down to the legs. Make sure you can find a pedal pulse. A lot of times students struggle with finding pedal pulses, especially on kids. It's kind of harder to assess than your brachial. But what my rule of thumb is, I always go to the second toe, and then I kind of go straight back to the middle of their foot. And you want to make sure you're not pressing too firmly. If you're pressing too firmly, you're going to collapse the artery and you're not going to be able to feel it. So lightly palpate. Wonderful. Or you can check the dorsalis pedis, which is right kind of behind his ankle. Good. Now you can see that Joey's a little bit mottled. This is normal in a newborn. I remember when I was a new nurse, I'd always get so nervous that my kids were so mottled. That's okay. But you want to use your parents as a reference. Ask the caregiver, the mom and dad, hey, does Joey always have feet that look like this mottled, or is this new? If it's new, a new finding, and mom's like, I've never noticed that before, then you'd be a little bit more concerned. It is so important in pediatrics to use the parent or the caregiver to help you with the history. And never ignore them. They know their child better than we do. Never write any of their concerns off, even if they're not valid. To you, it might not seem that valid. They can really be your helper in knowing what's normal, what's not normal. If they're like, he's never this quiet when you change his diaper. That's weird. That's a red flag. And you're also going to do a good peri area check. So you're going to really check the groins for diaper rashes, any yeast infections, and then and boys making sure that they don't have any hypospadias, their testes are both distended. Girls are more at risk for UTIs, so you always want to educate the parents. It's so important to wipe front to back, and then also making sure they're using maybe a diaper cream at home or any kind of protective ointment if the child has a lot of diarrhea, dehydration, things like that. Some tactics that I want to tell you about. Joey has actually been very cooperative throughout this assessment, but had he not been cooperative, you can use things like your badge to kind of distract them, sing a song. that's the best part of pediatrics is you get to be creative with it. And you have to really use diversional activities to get the children to cooperate. If you make things into a game, you know, like, okay, I'm going to listen to you, your heart, and then you're going to listen to mine, and we're going to see who sounds stronger. It makes it fun for them, and they're not as scared about it. And then the last thing I want to show you how to do is to swaddle a patient. You guys might have learned this in your OB rotation with newborns, but if not, it's really quick. This is definitely in every nurse's arsenal to know how to swaddle a patient. So you're going to take your bath blanket, this one's super big, and you're going to fold one of the corners down to make a triangle, okay? Pick you up here real quick. You're going to pull it so that triangle piece that you pull down is at the top of the bed. And then what you want to do is you want to align Joey's shoulders with the crease of the part you pulled over. Lay back down. Okay. You're going to take one side first and pull it over super tight. It's really important that his arms are down and it's tight. Because if not, you're going to have this. Look. I'm sorry. You're not helping me with this, huh? Okay. Hey! Okay. And tuck it in really tight. Perfect. And then you're going to reverse it on the other side and kind of flip it over. And then I kind of just tuck the bottom part under. So now that I have him swaddled, he's ready for his nap. So a big safety feature with children, especially at Children's Hospital, you're gonna need to educate the parents a lot. So back to sleep is always what we recommend with nothing else in the crib. So making sure no diapers, no wipes, no toys are in the crib with the patient, always back to sleep, okay? So I hope you guys wrote down some questions, some things that you noticed that went really well with this assessment, and then we'll discuss it on our Skype session. All right, thank you.